Good morning, good morning.
Hello. Good evening, ladies and gentlemen. Welcome to Learn from the Legends, the international webinar series organized by National Neonatology Forum Kerala Chapter, Indian Academy of Pediatrics Neonatology Chapter, Indian Academy of Pediatrics and National Neonatology Forum, Thrissur, headed by none other than Professor V.C. Manoj, President-elect 2025, NNF India. Today we have a renowned speaker, none other than Professor William P.D. Bode, President-elect European Society for Pediatric Research, Radboud University Medical Center, Nijmegen, Netherlands, who will enlighten us on management of PDA in 2023. This session will be moderated by two eminent neonatologists from India. Dr. Nilesh Rao from Bangalore is a product of JIPMER Pondicherry. Thereafter, he did research fellowship in neonatal and perinatal medicine from the University of British Columbia in Vancouver, Canada. He is a senior consultant neonatologist at Cloud9 Hospital, Bangalore. Dr. Anitha Haribalakrishna from Mumbai is associate professor and head of the Department of Neonatology, Seth GS Medical College and KEM Hospital, Mumbai. Now, I have great pleasure to invite Dr. V.C. Manoj to take over the proceedings. Wish you all a very wonderful learning experience. Thank you.
Thank you, sir. Hello, everyone. Good morning, good afternoon, good evening, depending on whichever part of the world you are in. Hearty welcome. We are truly honored to welcome you to this series, Learn from the Legends. We literally learn from the legends of neonatology. Today, I have great pleasure to introduce to you a true researcher and a legend as well, Professor Willem de Bode. he's a legend by all means, how you define it. A little bit about him, as is customary, introducing him. He obtained his medical degree at the Free University of Amsterdam in the Netherlands. Since 1999, he is a member of staff of Department of Neonatology of the Radboud Amelia Children's Hospital, Nijmegen, Netherlands. I'm not sure, sir, whether I'm pronouncing the names correctly. Pardon me for the mistakes. He was trained there in pediatrics and neonatology. His areas of interest are neonatal hemodynamics, extracorporeal life support, acid base, balance, the Stewart approach, neonatal surgery, and neonatal intensive care support. The focus of his research is actually on advanced hemodynamic monitoring, the area of talk today. He's involved in both experimental and clinical research in this field. In 2010, he defended his thesis entitled Neonatal Hemodynamic Monitoring Validation in an Experimental Animal Model. Since then, there was no looking back. Willem de Bode is the founder and chairman of the Dutch Working Group on Neonatal Hemodynamics. I am proud to say that he is also the president-elect of the European Society for Pediatric Research, and he had held various positions like the secretary of the section circulation, oxygenation, transport, and hematology of the ESPR, etc., etc. Willem is chairing ESPR ESN Special Interest Group. Neonatologists performed echocardiography, again the topic that we are going to discuss today, that is formulating European guidelines regarding the use of echocardiography in NICU. These days, we all know ultrasound has become the new stethoscope for all of us. He is a project leader of the topic of today, the BeNeDuctus trial, which has again, because if you remember in 2020, we had a symposium on PDA. 2021, we again discussed PDA. Now, this is, I mean, every year we again have a relook. How are we going to manage? So this is a dilemma that keeps happening. So management of PDA in 2023, what are the lessons we need to learn from the trial that the elegant trial that he and his colleagues conducted? That was an international multi-center randomized non-inferiority trial of early treatment versus expective management of PDA in preterm infants. Now, on the personal front, Willem de Bode is happily married and father of 4 children. His hobbies, I am told, are drumming, boat building, and theater. Wow, amazing. So, ladies and gentlemen, I do not want to keep you from the legend anymore. So, straight away, we will delve into the topic and then let's hear from the legend. Over to you, Willem.
Thank you so much for this introduction. It's a real honor to be part of this webinar. I don't consider myself a legend. I'm trying to do my best, and I will show you the results of the study we've performed. I'm going to share my screen.
If I can take the liberty, I just wanted to welcome Professor Eduardo Bangalari, who has joined us for this. Hello, sir. Thank you for joining. Over to you, Professor Willem.
Thank you very much. Thank you.
Thank you so much. Well, you already expressed some concerns, but because we are debating about the PDA for many years, it's already in the 1960s that the first report of a preterm infant was described with a PDA, and still we're not really sure how to handle that. So the title of my presentation is PDA in extreme preterm infants, to treat or not to treat, and I would like to focus on the results of the BeNeDuctus trial. First, I would like to disclose there are no relevant financial relationships, or I will not discuss any off-label use or investigational use in my presentation. And the BeNeDuctus trial was funded by these two organizations, one in the Netherlands and one in Belgium. But to start off, I would like to ask if it's possible to have a poll, and maybe I can have some assistance in that. I would like to ask the audience, if there's a patent ductus arteriosus in an extremely preterm infant, less than 28 weeks, what would you do? Would you treat it? Would you not treat it? Or don't you really know anymore whether to treat or not to treat? I will just give you some seconds, and I'm very curious what the opinion of the audience is. You can vote in the poll that's in your screen, and maybe we can see what the results are.
All right.
So 51% will treat the duct, 17% won't treat the duct, and 32% don't really know anymore. Thank you for that. So that's quite interesting. So the majority is either treating or in doubt whether or not to treat, and the minority wouldn't treat the duct in a preterm infant less than 28 weeks. Okay, can we have the next slide? There's the last poll. If you decide to treat, so that's for many people of you in extremely preterm infants, how would you treat? What's your your first way of treatment? Is that an NSAID, so ibuprofen or indomethacin? Is it paracetamol or acetaminophen? Always difficult for me to pronounce. Is it a surgical ligation? Is it transcatheter closure, or by other means? So I'm really curious what the results of this poll will be. Shall we have a look what the results are?
Yes, sir.
Thank you so much for your kind assistance. So the NSAIDs, paracetamol is 61%, so that's the first choice in this audience for treatment of a patent duct. Then 39% would use an NSAID, 1% surgical ligation. Thank you so much. Well, let's find out what I can tell you about my experience and our experience after the BeNeDuctus trial. As already mentioned, there's a lack of consensus. We're debating for many decades about the optimal treatment, especially in the preterm infants born less than 28 weeks gestational age and or a birth weight less than 1,000 grams. That's because there's a lack of evidence for or against different approaches. Well, let's first have a look at an active closure. So 51% of the audience is in favor of an active closure. And in that situation, you consider the patent duct as a causal factor for relevant neonatal morbidity or mortality. And in this slide, you can see on the left side, in the normal situation, the heart is pumping the same amount of blood toward the lungs as it is to the systemic circulation. So the QP is equal to the QS. However, if there is a significant transductal left to right shunt, there will be an increase of perfusion of the lungs at the expense of a decreased perfusion of the systemic circulation. And from a hemodynamic perspective, it's very plausible that this is causally related to problems with the lungs. The increase in perfusion to the lungs, it's very good, can be causal, or at least it is associated with pulmonary hemorrhage. We do see an association with an increase in bronchopulmonary dysplasia, maybe because of the hyperperfusion, the higher water content, the lower compliance, the higher need of oxygen, the higher need of ventilatory support. That might be an explanation for the increased incidence of bronchopulmonary dysplasia in the presence of a high volume transductal shunt. But also on the other side, a decrease in systemic perfusion might be the causal factor of renal failure, of necrotizing enterocolitis, cerebral injury. So that is how it's always been seen, and that's the reason why in the early years there was one always thought we have to close the duct. If you decide to close the duct, there are three different approaches. The first one is the prophylactic treatment, and then you treat all patients within a defined gestational range, age range, or a weight range within the first 24 hours of age. The second approach would be a pre-symptomatic treatment. So there's some kind of screening. Usually it's the echocardiographic screening program. And if you see echocardiographic indicators of a large transductal shunt, then that's the indication to start treatment. The last one, and that's the most popular one, is the symptomatic treatment. You don't treat until you see any problems that might be related to a patent duct. What is the difference between these three approaches? Well, if you have a prophylactic approach, you have the least risk of a prolonged exposure to a transductal left to right shunt. So probably also the least associated risk of a patent duct. However, because some ducts will close spontaneously, you have a higher risk of adverse effects of the treatment that you might not have needed because of a spontaneous closure. And the longer you wait, you have an increase of the prolonged exposure to the duct and therefore associated risk of a patent duct, but you have the decrease in risk of redundant adverse effects of the cyclooxygenase inhibitors. What we did when we designed the BeNeDuctus trial, we performed a systematic review and a meta-analysis, what is known from all the randomized controlled trials. And you probably have heard a lot of this. But as you can see, for the different outcomes, mortality, bronchopulmonary dysplasia, necrotizing enterocolitis, death or BPD, interventricular hemorrhage, there was no statistical significant effect of treatment. There were no differences. But what we know is that the treatment is effective in closing the duct. So what was concluded? It appears that treatment of a PDA is not associated with a significant reduction in severe neonatal morbidity. This was also being presented by a really elegant systematic review and meta-analysis by Suvik Mitra and his colleagues. And from that, it was concluded that placebo or no treatment did not significantly change the likelihood of mortality, necrotizing enterocolitis, or interventricular hemorrhage. So what we learn is we can give the medication, we know it will close the duct, however, the outcome will not be beneficial or better than without treatment. So that was why people thought, well, if it doesn't work, if it works by closing the duct, but it's not associated with an improvement in outcome, why shouldn't we wait for a spontaneous closure? And what we know on the right, you see that in a large percentage, it will close by itself, especially in the patients above 30 weeks, 28 weeks, but below 28 weeks, there is a less chance of spontaneous closure. And if you look at the left, it's more in the orange-red region. It's the less than 28 weeks. At day 4 of life, only 1/5 of the patent duct in these children will be spontaneously closed. And after a week, about 1/3 might be closed spontaneously. So there was more a trend to an expectant management. So in that situation, you don't regard the patent duct as a causal factor, but more a marker of immaturity. And like this, it's the immature infant that has an increased risk of a PDA. It's the immature infant has an increased risk of bronchopulmonary dysplasia, intraventricular hemorrhage, necrotizing enterocolitis, etc. But it's not the PDA that's causing this, it's the immaturity. So that's the difference in those two approaches. However, what we did is we again looked at all the randomized controlled trials that has been done from earlier days. And what we see in this slide is I show you the percentage of patients in the control group, either the placebo group or the expected management group, that was after all treated with COX inhibition or ligation. So that in the mean, it is about 50%. But up to 85% of the patients in the control group were treated. So is it a systematic review of treatment versus placebo? I don't think so. The best you can say, it is a systematic review of randomized controlled trials studying the early versus late or later cyclooxygenase inhibition. So is it still valid to say it appears that treatment of a PDA is not associated with a significant reduction in severe neonatal morbidity? I don't know. I'm not sure, because you treat them in both study groups. So it's probably not as that good studied. That's why we decided to have a different design, and we started the BeNeDuctus trial. It was a multi-center randomized non-inferiority trial that has been conducted in 17 neonatal intensive care units in the Netherlands, in Belgium, and in Denmark. And the objective was to investigate whether in extremely preterm infants, less than 28 weeks gestational age, with a PDA, an expectant management is not inferior to early treatment with regard to the composite outcome of mortality and/or necrotizing enterocolitis and/or bronchopulmonary dysplasia assessed at a postmenstrual age of 36 weeks. The inclusion criteria were, as said, less than 28 weeks gestational age, a ductal diameter of more than 1.5 millimeter with a ductal left to right shunt. And I will already tell you that's not the best parameter to assess the significance of the transductal shunting. It's not related to shunt volume. However, it's the most used criterion, and it was used to have a pragmatic approach in this study. What were the exclusion criteria? Of course, if it was not indicated, it was a contraindication for cyclooxygenase inhibitors. If there were signs of a increased pulmonary vascular resistance, so pulmonary hypertension, defined as a ductal right to left shunting more than 1/3 of the cardiac cycle. The presence of a congenital heart defect other than the PDA or a patent foramen ovale, life-threatening congenital defects, and the last one, the chromosomal abnormalities and/or congenital anomalies that are associated with abnormal neurodevelopmental outcome. That's because the outcome, neurodevelopmental outcome, is one of the secondary outcome parameters in this study. So what we did is we did not design a placebo-controlled trial on purpose, because in our understanding, we would have a high chance of making the same mistake again as was done in former randomized controlled trials. Because if in the course of a patient it's not as you would like, there are complications, we think it will be very it could be considered that, well, probably the patient will receive placebo. Let's give open label treatment just to be sure, because it's still a dogma in our head that doctors need to be treated. So what we did is that we randomized the intention of the attending clinical team. So either you consider the duct as a causal factor, or you consider it as a sign or a marker of immaturity. So it's very important that the whole clinical team must be in clinical equipoise. There's no difference in evidence in either treatment or no treatment. So that took a lot of time to have all the clinical teams in clinical equipoise, because what we wanted is that in the expectant management group, that is really a group that we can compare without open label treatment. As you can see from this slide, these are the study procedures. There was a inclusion and a randomization at an early age of postnatal age of 24 to 72 hours. We know there was a diameter of the duct more than 1.5 millimeters, and either they were randomized to treatment with cyclooxygenase inhibition. In this study, it was ibuprofen, or an expectant approach. If we look at the early treatment, ibuprofen was started at a median postnatal age of 63 hours in a median dose of 10.5 milligram per kilogram per day in 3 consecutive days. After the course, it was checked whether the duct was closed. If it was closed, the patient went into follow-up. It was still open, a second course could be given, and it was at the disposal of the attending clinical team. And then it was again checked, is the duct closed? If it was closed, into follow-up. It was still open. It was at the disposal of the clinical team whether or not they wanted to give a third course, a fourth course. We decided not to have to be mandatory to close the duct, even with a surgical ligation or a transcatheter closure. So we defined some criteria based upon you could decide to have a ductal ligation. But this was all, it was the intention to treat it as the clinicians would normally do. On the other side, the expectant management. You know the patient had a duct, but we don't look at it anymore. We don't treat it anymore. As you can see here, there was one echocardiogram performed at the age of 6 to 8 days. However, that was only allowed if it was blinded for the clinical team. So there was an echo being performed and the clinical team was not informed about that. If we talk about expectant management, it is really, really expectant. We didn't do anything aimed at treating the duct. So it's characterized as watchful waiting. And as we said in the study protocol, it was essential that neonatal management is similar in both arms, with the exception of the prescription of ibuprofen and routine echocardiographic examination after finalization of the course. No extra interventions are to be undertaken with the intention to conservatively prevent a PDA in the expectant arm, such as fluid restrictions and or diuretics for that reason. Of course, it was allowed to give paracetamol for an analgesia, so in an analgesic dose, which is lower than the dose which is commonly used by a lot of you, as I understand from the poll, for ductal constriction. We want to prevent open label use of ibuprofen in the expectant management group. So we have had a very high threshold, and here you can see the open label criteria, and it's really difficult to fulfill all these criteria. So it made it very difficult to give open label treatment. The primary endpoint of was the composite of mortality, necrotizing enterocolitis, which is a Bell stage 2A or higher, and or bronchopulmonary dysplasia, the moderate to severe, defined as the need for supplemental oxygen or positive pressure ventilatory support at a postmenstrual age of 36 completed weeks and diagnosed following the international standard criteria by Bancalari, including an oxygen reduction test according to Walsh. We defined the non-inferiority, and that was defined as an absolute risk difference with an upper boundary of the one-sided 95% confidence interval of less than 10% points. So if the expected management was equal as the early treatment, there was a difference of 0%. We would accept a 10% higher incidence of the primary outcome in the expected management group, and still defined as non-inferior and inferior, as the right, the upper 95% confidence interval limit was within the blue range. And for the power calculation, we estimated a priori risk for a primary outcome event of 35%, a type 1 error of 5%, and a power of 80%. We determined that a sample size of 564 patients, so 282 per group, would be required to exclude the non-inferiority margin. From December 2016 to December 2020, we assessed 1,600 infants born below 28 weeks, of which 1,344 were informed about the BeNeDuctus trial, and you can read over here what were the reason for exclusion of the patients. Of them, for 442 patients, we obtained informed consent, and we were able to randomize a total of 273 patients. For the study population, the median gestational age was 26.1 weeks and a median birth weight of 845 grams. 136 patients were randomized to expected management, and only one patient was treated with open label ibuprofen, which brings the open label treatment percentage only at 0.7%. And to bring you back in memory, the mean of all the randomized controlled trials was 50%. So we were very happy that we succeeded with our design to limit the open label treatment in the expected managed group as good as possible. If we look at the early treatment, the ibuprofen treatment, 137 patients were treated with ibuprofen, and after one course, 70 were closed, brings us to a closure rate after one course of around 54%, which is in the same amount of studies being published. If we look at how it was done, because it was according to local protocols, here you can see all the different regimens, but the majority get the normal 10 milligram per kilogram per day, and then 5 in the 3 consecutive days. If a second course was needed, so that's around the 4th to 5th day, it's still 10, 5, and for the third course, so in the second week of life, increased dose 18, 9, 9. For the maternal characteristics between the expectant management group on the left and the early treatment group, the ibuprofen group on the right, there was only one significant difference, with a higher incidence of maternal HELLP syndrome within the expectant management group. For the rest, there were no differences. There were no differences in the neonatal characteristics between the two study groups. And I would like to point out that we really had small infants. And what is, I think, really important to understand, that in our population, about 1/4 of the patients were invasively ventilated directly after birth. And I think that's a lower percentage than is normally observed or presented in other studies. So let's go to the results for the primary composite outcome. What we did see for the composite outcome in the expectant management group, 46.3% had the primary outcome in comparison to 63.5% in the early ibuprofen group, brings us to a absolute risk difference of minus 17.2% with the 95% confidence upper limit of minus 7.4%, a risk ratio of 0.73, as you can see, significant. To put it in this graph, for the primary composite outcome, it's definitely non-inferior, but maybe you could say it's superior, but we're not allowed to say it's superior because the design is a non-inferiority trial. But that's for the composite outcome. Let's have a look at the components of the primary outcome, but not before I also show you that for the per protocol analysis, the results were similar. For the components of the primary outcome, the necrotizing enterocolitis, the moderate to severe bronchopulmonary dysplasia, and mortality, you can see that it was mainly related to bronchopulmonary dysplasia. As you can see in this graph, for bronchopulmonary dysplasia, the moderate to severe, the primary outcome, it was because of an increase percentage, 50.9% in the early ibuprofen treated group versus only 1/3 in the expected management group, resulting in a minus 17.6 absolute risk difference and a risk ratio of 0.66, significant. And as you can see over here, also similar results in the per protocol analysis. Let's look at some secondary outcomes because we would like to know what about cerebral injuries. The intraventricular hemorrhage, no significant differences. No difference regarding renal failure, no differences in pulmonary hemorrhage. We also did some subgroup analysis. As you can see, the less than 26 weeks and the 26 to 28 weeks, it all is non-inferior. What we see is for less than 1,000 grams, it's non-inferior. For the over 1,000 grams, it's looks, but according our definition, the upper limit is above plus minus 10%, but we think this might be related to the really small number because there were not that many children more than 1,000 grams in our study population. This was a very intriguing finding because we looked at the difference between males and females. And what we see that especially in males, they had an increased risk of the primary outcome in, and if you look at this, it's really significant. For the females, the upper limit is plus 10.5. So it's, to be honest, it's not according our definition of non-inferiority because it just over exceeds the limit of our definition, but also that might be related to the lower amount, and that's what we think. What are the limitations and the strength of this study, in my opinion? Limitation is definitely that the enrollment stopped after inclusion of only 273 patients. There was almost the half of the patients that were powered. That was due to slow recruitment and discontinuation of the funding. However, the results are as they are, and with a significant results. As already mentioned, the transductal diameter is not the best indicator for hemodynamic significance. Moreover, there was no one dosing protocol for the early treatment, but it was according to the local protocols. But as I showed you, it was in the normal range that it was used, and it was according to the guidelines that are used in the Netherlands, in Belgium, and in Denmark. The strength is that this is the largest randomized controlled trial regarding the early targeted treatment of PDA, and we only have 0.7% open label treatment in the expectant management arm. So the conclusions are that non-inferiority was shown for expectant management in extremely preterm infants with a gestational age below 28 weeks with a PDA compared to early ibuprofen treatment for the composite outcome of mortality or NEC or moderate to severe BPD assessed at a postmenstrual age of 36 weeks. This was mainly due to a significantly lower incidence of bronchopulmonary dysplasia in the expectant management group. Significant sex difference was observed for the composite primary outcome, showing an increased risk in male infants after ibuprofen exposure. Conducting a randomized controlled trial in critically ill newborn infants is definitely very, very challenging, I can tell you from my personal experience. Then the discussion that, in my opinion, the results suggest harm that is associated with early ibuprofen exposure, and that's largely driven by a higher incidence of moderate to severe bronchopulmonary dysplasia in the early ibuprofen group than in the expectant management group. And the question is the cure that we are using more harmful than the condition itself? So we're trying to treat the PDA in our attempt to prevent any damage and injury to the lung, but maybe is ibuprofen, could it be that it is directly related to pulmonary injury? And what do we know about the relation between ibuprofen and pulmonary injury? Because of course, we always thought there was a relation because you give ibuprofen because of a PDA, and PDA is probably the causal factor of the pulmonary injury. But there are some observational studies, not large study cohorts, but that suggest that there's a direct relation between ibuprofen exposure and bronchopulmonary dysplasia. And when we look further into the literature, we do have some experimental evidence of inhibition of the angiogenesis by ibuprofen in human umbilical vein endothelial cells. In the retina of neonatal rats, you can see it also in zebrafish with a cardiovascular development. And recently in a paper in last year, 2022, it was described in a cohort only of 70 preterm infants that there was a decreased level of angiogenic factors after ibuprofen treatment. So it's quite intriguing. So what are the next steps for us with all the data from the BeNeDuctus trial? There will be a neurodevelopmental outcome assessed at a corrected age of 24 months. There will be a secondary analysis of the relationship between the transductal shunt volume on outcomes, because I mentioned that the ductal diameter, which was used as an inclusion criteria, is not the best marker of transductal shunt volume. So we got all the echocardiographics examinations, and they are going to be examined by the pediatric cardiologist that is a PhD candidate, and she will look at all the videos in both study groups. And I would like to know what the effect is in the patients with a high shunt volume. From 2 centers, all patients in the BeNeDuctus trial, so a selection of the study population, we have the data from the near-infrared spectroscopy from the brain, so we can have a look at that. We're going to have a long-term echocardiographic follow-up of the patients with a non-documented ductal closure as discharge. So if you do an expectant management group, what to do after that? And of course, we want to dig in deep into the role of cyclooxygenase inhibition, but also paracetamol on pulmonary angiogenesis, because we do know if you have an effect on the prostaglandins, it probably will also have an effect on the angiogenetic factors. And as you can see from this, in the paracetamol is in the same pathway, only a bit more downstream. So I'm not sure, and I think it's really important to have a look into that. For that, I want to close to thank, of course, all the parents of patients that were in this study, because I really admire that in a crisis with a preterm infant on the intensive care unit, you still are able to discuss whether or not you want to consent on a study like this. I really admire the parents on our ward. All the study sites, the patient organizations that were involved, the trial coordinations, the biostatistician, the data safety monitoring board, all my colleagues, and of course, the funding. And I would like to thank you very much for your attention, and I'm very happy to answer any question that may raise during this talk. Thank you very much.
Thank you. Thank you so much, Professor William. It was a very interesting lecture, amazing journey doing an RCT on critically ill neonates, and then avoiding all the open label treatments in the treatment group. It's such a marvelous study. We look up to you for this. Now we'll have a panel discussion. For that, I would invite the moderators for this panel. Dr. Anita Haribalakrishna from Mumbai and Dr. Nilesh Rao from Bangalore. Over to you, Anita and Nilesh.
Thank you, sir, for the kind introduction. And first of all, I would like to thank Professor William Boote, sir, for enlightening us with this the most relevant research on PDA management, current controversial topic. So thank you, sir, for the update. And so I just want to summarize what actually Professor William had narrated to us in this short talk. So initially he has told us about the lack of consensus on the PDA management, and also about the lack of effectiveness of the PDA management with the drugs, the COX inhibitors, on the clinical outcomes in preterm infants. And then he has narrated to us about the three basic approach for duct closure, which include prophylactic treatment in any baby as per the gestational age and for the time period, and then about the pre-symptomatic treatment, that is according to the echocardiographic findings, and third is about the symptomatic treatment, only if the treatment is required. These are three scenarios he has explained to us in detail. And then he has come to us about the trial proper, that is the BeNeDuctus trial, where the composite outcome of mortality, BPD, and NEC were discussed in his trial. So the basic question was why can't we base
Dr. Anita, if I may, taking the liberty, we have a lot of elite audience in this group. Professor Bangalari, Professor Subair Agai, Dr. Amit Mukherjee, etc. Would any of them like to start by asking questions? Because I can see them all here.
Okay, sir. So we can ask the questions then. So over to Dr. Nilesh for his session. Hand over to Dr. Nilesh. And then we can ask questions from the audience also, other prominent neonatologists and the pediatric cardiologists.
Sure. So thanks, Dr. Debut, for the excellent in-depth analysis of the trial. Very insightful indeed. So we know PDA is one of the most perplexing issues. There have been many trials of late. I think BeNeDuctus trial, then there is the Baby Oscar trial, PDA Tolerate trial for 6 to 14 days. I think there is more and more evidence for going conservative or for expectant management, and the evidence base is strengthening. However, to me, there are certain questions, more and more questions come up with these kind of, the way the pendulum has swung completely to the extreme. So the important thing I want to ask here is the messaging that we are sending to clinicians or bedside. What will they do when they are faced with a baby? So these are the questions I have in mind. I think then we can move on to questions from the other panelists. So one of them is, can we extrapolate these data to all group of neonates. We know that the very preterm babies are different from the extreme preterm babies. And of course, we are now faced with a lot of babies who are less than 26 weeks. And we extrapolate the same kind of this information that we have from these trials, where the median age is around 26 to 27 weeks, these babies. Can we safely recommend conservative management for all babies? So just looking at individual studies, there was this one Canadian data which compared the two epochs between two units. One was conservative and one was going on to, early treatment. And they found some data where they found like chronic pulmonary hypertension, and there was a increased incidence of mortality in these babies. So looking at individual studies, will it give us more information?
Well, thank you very much for this question. I think it's really important to talk about how to interpret the data from this BeNeDuctus study and how to relate that to other studies and how to translate that into a daily practice, because that's why we're doing the research, to help us in our daily clinical practice. What we did and what we always do in a study is that you talk about the average patient and the average treatment. And of course, the individual patient you're treating probably is never the average patient. So that makes it very difficult. However, in the BeNeDuctus trial, it was shown that at least non-treatment, the expected management group, was not inferior to, even there's a suggestion of superiority. So I think if you decide not to treat, you have the data that you have the how do you say it? The confirmation that it's not wrong to do. Doesn't mean that there's no patient at all that you should treat. I don't know. If you ask my personal opinion, I don't think so. From a pathophysiologic perspectives, I can't imagine that it's good to have a very high pulmonary perfusion at the cost of a very low systemic perfusion, that is beneficial for a patient. So I think we should try to taper out which patients are at risk because of a high ductal shunt volume. But the next question is, with the data that suggests that it might be the treatment, so the ibuprofen, that has a detrimental, or could have a negative effect on pulmonary development, especially on the angiogenesis, maybe we're using the wrong drug. Should we look for another drug, paracetamol? I'm not sure, because as I already mentioned, it's in the same mechanism in the inhibition of the prostaglandins. It's more downstream. Is it another more innovative drug? I'm not sure. I think we should have a look at it. Maybe transcatheter closure could be very interesting. I would be very interested in performing a study randomizing early transcatheter closure versus the expected management. There's the pivotal trial currently pending, as you know, and I'm very interested in the results, but in that trial, the transcatheter closure is only after failed medical closure. So all those patients are already being treated with either ibuprofen or paracetamol. And if there's a causal relation between the prescribed drugs and the bronchopulmonary dysplasia, there might not be that great difference. So I think that will be interesting. So to summarize, and hopefully I've answered your question. For now, I think you have to be aware that I think the data show that it's not that good to treat with ibuprofen for the whole group. I would try to aim for the patient with the largest transductal shunt. You can discuss about half a day, a week, about what is a hemodynamic significant duct, but we've got criteria, we can use that and try to work on them. But then still, I'm not sure how to treat them.
Thanks, Dr. Debord. I would like to ask our esteemed panelists, if any of them have a question, kindly come forward and please ask the question.
Yeah, I would like to just make a comment. This is Dr. Bancalari.
Good day. Nice meeting you.
Hi, how are you doing?
Sir,
Hi.
thank you. Thank you for joining.
Yeah, first, I would like to congratulate Dr. Bode and his collaborators for a fantastic trial that certainly doesn't give us the final answer, but gets us closer. And I agree with most of his comments. In fact, we published a paper in Journal of Pediatrics in 2012 with a much smaller population, but a very similar design to the one that Dr. Bode used, and found exactly the same results. The incidence of death and moderate or severe BPD in the babies that receive ibuprofen earlier was significantly higher than in the babies who didn't get the drug and therefore remain with the ductus open. This was exactly the opposite of our hypothesis and what we were expecting. So I think that when we saw this paper, it really reassured us that this, in fact, is probably what is happening. And I fully agree that the most likely explanation is that, yes, ibuprofen is effective, closes the ductus, but there must be secondary effects that counterbalance the beneficial effect of closing the ductus and produces harm. And I just would like to remind everybody that something very similar happened with prophylactic indocin trials many years ago. Dr. Banstra in our group published one of the first trials on prophylactic indocin, and it was very clear that those babies who got prophylactic indocin had a lower incidence of IVH. So we were all expecting a much better neurological outcome. What happened? Exactly the same thing that happened with these trials. Neurological outcome was the same, was not improved, even when those babies had lower IVH. So again, that suggests that indocin is doing something good, closing the ductus when you use prophylactically, but it must be doing something bad to the cerebral perfusion probably, because long-term neurological outcome, despite the lower incidence of IVH, did not improve. So I fully agree. I think that there is something here that suggests that these drugs have negative effects, and the balance is what we have to look. And I agree again 100% that we have to be careful not to say that this trial suggests that we don't have to close any ductus. We just have to develop tools that allow us to be more precise and close those ductuses that are significantly hemodynamically. And again, that's easy said, but not very easy done. But I think that will be the answer. We will have to decide which are the ductus where the repercussions are so bad that despite the negative effects of these drugs, it may be worthwhile closing them. And beyond that, I think that the most important thing will be to try to develop a drug that closes the ductus without the side effects. That again, I don't know how long it's going to take, but that really should be the aim. So thank you very much for the opportunity to listen to this wonderful presentation and make a few comments. Thank you.
Thank you very much for your comment. And yeah, I think that's our major task, to find out how we can treat the patient with a high transductal shunt. And that's what I'm really interested in our study population. When we have analyzed all the echo data in the patient with a true high shunt volume, maybe the benefit of ibuprofen is higher than the risk on the pulmonary angiogenesis. So if we have a look at that, we'll come back, and maybe that can tell us, because maybe it can tell us that in the only selected population, the benefits outweighed the adverse effects of ibuprofen in that selected population. Yeah.
Thanks, Dr. Bancalari, for the excellent insights. Any other panelists? Kindly come forward.
This is Dr. Zubair Agai. I'm the professor of neonatology at Thomas Jefferson in Philadelphia. Dr. Diebold, thank you very much for a wonderful study. And as we all know, this is the best evidence for treating or not treating for the PDA in premature babies. I just have a couple of comments. The first one is, how did the practices change at your institution and in Europe after your trial? Because it's so hard to convince my colleague here not to do an echo and manage the baby on conservatively and not to treat this baby. So how is changing your practice there after the trial? My second question is is a comment about the follow-up on neurodevelopmental outcome. I'm really very happy that you're going to do a neurodevelopmental outcome in these babies. And as you and we can guess, the neurodevelopmental outcome is going to be worse in a baby who we are treated for the PDA. The first reason is they had more BPD, and we all know the BPD is associated with abnormal neurodevelopmental outcome. But the second one, which is more important, is the ibuprofen affecting the angiogenesis. So I'm sure it's affecting the angiogenesis in brain too. And as we found with the endomethacin, we are going to have some abnormal brain development with the ibuprofen in premature baby. Thank you.
Thank you so much for your comment, and I fully agree about the follow-up. And moreover, we would like also to have a follow-up of because a lot of pediatric cardiologists are worried about the patent duct not being treated and to have a prolonged exposure with the risk of pulmonary hypertension. So there are conflicted data from the literature whether or not that's a really important issue, but we're going to follow up all the patients in the BeNeDuctus trial in the expectant management group. Getting back to your first question about did we change our protocol? Yes, we did. In the Netherlands, all the NICUs participated in this study, and we do have a collaboration on research, on guidelines, and on benchmarking. So it's always interconnected. And now with the results of this study, we advise not to have a standard echocardiographic screening, not to treat the duct early. That is based on the current knowledge, but to be honest, I think it will be a very dynamic document, because with additional observations from our study population related to the outcomes related to the shunt volume, it might be that we can define the specific population you have to aim for treatment in an earlier stage. So at this point, based on the current knowledge, we have the guideline not to treat early, not to have a standard echocardiographic screening program. That's quite different that I was used to, because 5 years or longer ago, I would treat every duct even within the first 24 hours. But I've learned, and I think from the data right now, that's not the way to go.
Thank you. Any other panelists kindly come forward? We have a lot of questions. Once the panelists come forward with the questions, maybe we can go on to the Q&A session.
Yeah. So any other questions from the panelists, please?
I think, Nilesh, carry on with the questions. I think there are no more questions.
I'll hand over to Dr. Anita. Maybe we can start taking the questions. There are almost 29 questions.
Yeah. So the first question actually, it's likely until how many days of life the medical treatment for closure of ductus is expected to have a response?
That's a very good question. We know that when you start treatment, the duct within the first week of life, it will be the most effective, and the effectiveness of the efficacy of the medical closure is decreasing after that. But that was probably also related to that the dosage was not increased after 1 week. So the advice right now is after 1 week to double the dose. And what's also very interesting is that it is advised to give enterally or orally ibuprofen, which might be more efficient than the intravenous administration of ibuprofen.
Nilesh, second question, please.
So there's a question from Dr. Vishal. So he wants to know about markers like, NT-proBNP. Any role for these for deciding about treatment of hemodynamically significant PDA in symptomatic or pre-symptomatic pneumonitis?
At this point, I don't think that will have any consequences based on the current data we've got. There is a relation between heart failure or congestive heart failure. So if you got really cardiac consequences of a large transductor shunt volume, you will have an increase in your NT-proBNP, etc. But I don't see any role at this point for standard monitoring of those biomarkers. No.
Okay, the next question is from Anjali Kulkarni. She's asked, just want to confirm that no supportive management, that is fluid restriction, was carried out in the expectant group.
Yeah,
So
I can comment on that because that's a good question. I definitely can say that there was no extra fluid restriction or more diuretics in the expectant management group. Even paracetamol for analgesia was less used in the expectant management group. Moreover, for me, it's not logic to use fluid restriction in a patent duct because the problem is pulmonary hyperperfusion, and from the lung edema, it would be beneficial to give diuretics and fluid restriction. But what you have is at the expense of the systemic perfusion. It isn't logic to give then fluid restriction, and it has been shown in a very nice, elegant Belgian study that when you give fluid restriction and diuretics, you have a real important decrease in your cardiac output and in your systemic blood flow. So your systemic perfusion, that you're more at risk for damaging. So I'm not using fluid restriction or diuretics for the purpose of treating a duct.
the next question is about the IVH percentage in both groups, which have already given a secondary outcome. So you want to give that answer? That's 29% versus 32% in the grade 1 and grade 2 IVH groups, and more than grade 3, that is 8% in the expectant group versus 6% in the ibuprofen group, early ibuprofen group. Nilesh, you can ask the next question.
Professor Debut, there are a lot of questions on paracetamol. So in this country, in India, based on a few trials, a lot of paracetamol is being used even in extremely preterm babies. I'm sure many of the units are using it. So I think most of the questions center around that, the dose of paracetamol, and of course, whether paracetamol is the efficacy of paracetamol. Do you have any experience with that or in your unit?
Personal experience, no, because I don't like to use paracetamol, but I'm biased. I know it's used, it has been tested, it's effective in closing the duct, and there are contradictory data whether it's as effective or less effective than ibuprofen. It depends on the study you would like to refer to. I personally have still concerns about longer term outcome related to the brain, etc. And I'm not sure whether it's safe. We do use a lot of paracetamol in the analgesic dose, but for closure, it's a very high dose. But that's my personal opinion. If you ask Afif El-Koufash, if you ask Patrick McNamara, they would say, yeah, you can use it. But with the data from the BeNeDuctus, with also the concerns, also from Cochrane data, also from Karel Allegaard, who's very good in the pharmacology, the concerns on later term, I think that makes me reluctant to use paracetamol. And if I see that the expectant management group is not worse, maybe even better, then that gives me the argument to stay away from paracetamol at this point. Yeah, but maybe in the future it may show a good alternative for ibuprofen. However, my concern is it's still in the same pathway, only more downstream. So maybe it has the same effect on the pulmonary and angiogenesis. So I think that's really important to try to pinpoint that out. What are the problems? Yeah.
Raju Malhotra has asked, any scope of NIRS in assessing significance of PDA? He's asking about NIRS.
I'm sorry, I couldn't understand the question. I'm sorry.
Sorry, any scope of near-infrared spectroscopy in assessing a PDA? So one has asked that, Raju Malhotra.
Yeah. We haven't analyzed the data about the near-infrared spectroscopy yet, and we're currently working on that. The nice thing is that's from 2 centers in the Netherlands that have a standard NIRS monitoring. That's the Utrecht, University of Utrecht, and the University of Groningen. And they both published on the effect of a PDA on cerebral perfusion and oxygenation, and they were contradictory. So that's nice that we're now collaborating, because the Utrecht is telling me that in a significant PDA, you got a decrease in perfusion and oxygenation of your brain. And that was not shown in the study from our colleagues from Groningen. So this is nice in this study population, both groups from those 2 centers. I'm very eager to see the results, and I will come back as soon as possible as I've got the results and we analyze them. Yeah.
So Dr. Anil Kumar has a question about a combined treatment, like any crossover trials with paracetamol followed by ibuprofen, or the other way around. Any trials where 2 drugs are, whether any such trials are available?
Not randomized controlled trials, but it has been published the use of combined treatment, so both paracetamol and ibuprofen, and there was an increase, as I recall it correctly, of the closure rate. However, my concerns is, given the data, I'm not going to do that because ibuprofen, I'm not sure whether it's safe. There are arguments to say it's not safe. There are too many adverse effects. And if you increase that again with the paracetamol, I would not do that. It would not be my advice. If in a selected patient you want to treat, I think you should use the most effective, and that probably is ibuprofen or paracetamol. What we did in the guideline in that situation, because I'm not the only one, but it's decided on the consensus within the Netherlands, we are going to use paracetamol.
Okay. So A.D. Budi Dharma, he has asked a question. Could you elaborate about circulatory support and how to maintain that issue, since in your trial, it's 0 circulatory support in both groups? So do you want to comment on that?
Yeah, but the circulatory support was only during the transition. So that's the first hour after birth. There was no difference in the use of inotropic drugs during the admission. So no difference in cardiovascular support later on. So it was not that in the expectant managed group there was more need for inotropes, vasopressors, or whatever. So there was no difference in those groups.
So, Neeraj, you can ask the next question, please.
So what was the distribution of steroid and caffeine use within the first 2 weeks of life? I think it's about the postnatal steroids, I think the question is.
Yeah, we both looked at prenatal and postnatal. They were similar within those groups, and the caffeine exactly, there was no difference in those because all co-medication was also studied. No difference between the groups.
So, Liber Torres was asked, how much liquid can be administered to an extreme premature infant less than 1 kilo from birth and the days after? So, they are asking about the conservative treatment of ductus and the need for fluid, whether fluid can be administered liberally or restricted fluid can be given in babies who are less than 1 kilogram.
As I understand you correctly, it's the question about how to have the fluid management of in a patient with a PDA, and I would use the normal fluid intake, the fluid management, and not to have a different. So no increase, no decrease, no restriction or liberal. The normal fluid intake in patients with a PDA.
Dr. Debut, sorry, Dr. Anita, please.
No, okay. So the next question is the Nuhu Numeri has asked, if I have a preterm 26-weeker who was difficult to ventilate and was found to have HSPDA at day 3, should we treat and using what, ibuprofen or paracetamol?
Yeah, that's a difficult question because, as you understand, there were very small infants in the expectant management group in the BeNeDuctus trial. And when they were on the ventilator and the course was not beneficial, there was a lot of discussion about, okay, is this a duct that we really needed to treat? So I was always available on the phone 24/7 whenever someone considered open label treatment in the expectant management group. And we always think about, well, probably that is caused by a patent duct, because in our differential diagnose, patent duct is one of the major items probably causing the prolonged ventilatory support. I did see in many cases that, okay, they had a look at the duct and it was closed. So it was not caused by the patent duct. And I always explained that if you are, and that's why it was so important to have clinical equipoise with the clinical team, that the patent duct is only a marker of immaturity and not a causal factor. Then you can say the problem in this specific immature baby is probably most related to the immaturity of the lungs. And treating the duct, especially if you're giving a drug that is, there's data suggesting it might injure the lung again. So that's why I can motivate not to be too early with treatment of those babies. If you have a heart that's really enlarged and you have signs of heart failure and you've got a huge transductal shunt, and I think that's what we're going to check in the data from the echocardiography from both groups, I think I would treat the baby with ibuprofen. Thinking, but I'm not sure, thinking it outbalanced the beneficial effects of treating versus the adverse effects. But I know I am at risk for adverse effects, either due to the immaturity, either due to the PDA or the effects of the ibuprofen. Yeah.
Dr. Debut, there are a few questions about what you consider, given your background, as a hemodynamically significant PDA. I think as per the trial, probably they want your opinion too.
I think as you probably know, I really like the neonatologist performed echocardiography. It brings so much to your skills to be able to judge about hemodynamic significance. I would like to refer to many papers being written about that also within our European group. I think there are two major indicators. The first one is the transductal shunt. If it's a pulsatile shunt pattern, that's probably a proof of a high shunt volume, especially when it's together with a retrograde diastolic blood flow in the descending aorta. So post-ductal, if you see a retrograde diastolic blood flow, those two indicators are associated with a real high shunt volume. As said, a large ductal diameter is not, because it's only depending on how you measure through a duct. And if you got a tube and you have it in the wrong direction, you can have a very high diameter, but it's not the real diameter of the duct.
Okay. So how do you manage a large PDA with bidirectional shunt in a full-term baby with pulmonary hypertension? So they're asking about pulmonary hypertension in full-term baby.
Yeah.
And as a
Well, and then in that situation, if I got a full-term baby with an increase in pulmonary vascular resistance, so the pulmonary hypertension, in that case, the duct is my friend, not my enemy. And I like a duct in a pulmonary hypertension because I like when it has a right to left shunt. The problem is you get a desaturation of your postductal blood. However, it will prevent any right ventricular failure. If I may, I think what we always did is if you got a right to left shunt that our first reaction was, and you got then a low blood pressure and low oxygen saturations, our treatment was to increase systemic blood pressure by giving vasopressors. The problem, however, is that you get an improvement in your blood pressure, you get an improvement in your oxygenation, however, probably at the expense of the cardiac output. Because if you have a higher afterload for the right ventricle, because that was the primary problem of high pulmonary vascular resistance, and now you also have a very high systemic vascular resistance, you get an increased risk of right ventricular failure. So you will have a decrease in cardiac output, because in an open duct with a good cardiac output on the right, it will preserve your postductal perfusion. And what I did, I calculated with a normal cardiac output and oxygen saturation around 60%, so really low, you have a higher oxygen delivery than with an oxygen saturation of 100% and a cardiac output of only 50 mLs per kilogram per minute. So, and what is our aim? To have a good oxygen delivery. It's not to have the right figures. So that's my advice.
One question. One question is, if you have the possibility to close the PDA by catheterization, what age do you prefer to close a hemodynamically significant PDA?
I would wait for hopefully a spontaneous closure within the first 2-3 weeks. If there's no spontaneous closure and I've got signs of a high shunt volume and signs of ventricular failure, left ventricular failure, dilation of the left ventricle and left atrium, I would consider a transcatheter closure. It's been published and there's getting more and more experience in using a new FDA approved device specifically for this population, and it can be as small as in a 500-gram baby in an experienced setting, even bedside, guided by ultrasound on the NICU. So that would be very nice. To be honest, we can't do it on our ward at this moment, but I'm considering to try to arrange that, because maybe that might be the future, but I'm not sure yet. We have to first to study that.
Yeah. Dr. Prashant has asked, in low and middle income countries, what would be the research priorities in management of hemodynamically significant duct?
What I would do is first wait for spontaneous closure. If, as I mentioned, if you have to close, don't use IV ibuprofen because it's extremely costly and I don't understand why that must be. Please use the oral or enteral because it's much cheaper and it's far more effective. So that's what I would like to advise.
There are a few questions about the role of diuretics.
Before we proceed further, can I take the liberty, I mean, to interrupt? Professor Willem Debo, how much time do you have now? Because we have taken all the time that you have given us.
No problem at all. I still got 15 minutes, so that's no problem. And I love to answer the questions. I will do my best to answer them, but please feel free to ask.
Thank you. Thank you. Please carry on, Nilesh.
So the role of diuretics, again, nebulized furosemide and this is like IV furosemide. Do you think these are useful?
Well, I already explained that I'm not in favor of using diuretics or fluid restriction in patients with a patent ductus with a left to right shunt. There are some contradictory results about the effect of furosemide on the prostaglandins, and it was suggested that it increases the prostaglandin levels, so it's opening the duct, but in other studies it couldn't be confirmed, so I'm not sure, but I wouldn't use diuretics in these patients.
Okay. So, was there any increased incidence of pulmonary hemorrhage in babies who were not treated? Sorry, he has also written, I might have missed. Yeah.
Yeah, the pulmonary hemorrhage is quite intriguing because in the DTEC trial, which was performed several years ago in Australia by Nick Evans and Martin Klugo, they observed a decrease in pulmonary hemorrhage in the indomethacin treated group. So, but I've discussed it with Nick Evans, and what is remarkable that in their group, in the treated group, so with indomethacin, the incidence was 25% of pulmonary hemorrhage. That's 1 in every 4 infants. That is large. And in the treated group, it's 10%, 1 out of 10. It's still very high. And I couldn't understand that because in our population, it's 2 to 3%. So I've asked, how is this possible? And he said, well, he doesn't understand. There must be a problem with ventilation. I don't see pulmonary hemorrhage very often. I think we have a different approach. We try to aim at non-invasive ventilation as much as possible. I don't see the it has been, I think, about 4 or 5 years ago that I experienced a patient with a pulmonary hemorrhage.
Okay. But it is very common in actually where we are practicing in babies who are less than 28 weeks. Pulmonary hemorrhage is one of the common complications we see in babies who are 800 grammars, 700 grammars. Maybe associated with sepsis also. That is also common here. That may be the reason also, but it's very common here. Yeah.
Can you tell me what was the average percentage of patients that are invasively ventilated in the first week?
Here also we don't do, we all promote non-invasive ventilation only maybe 20% of the total babies maybe, yeah.
This is so intriguing that there are so many differences in the incidence of such conditions, and I'm intrigued by it because why is that? I don't understand. I would like to understand, but I can't give you an explanation because it's such a large difference. Yeah.
Sure. Dr. Nilesh, next question, please.
I think maybe I should ask a question if I have the liberty to ask. Dr. Debu, do you think, do we need further trials with respect to this, with stringent clinical and echo criteria, looking at the degree of left to right shunting, the LV diastolic function, systemic perfusion, and without contamination? I know your trial was extremely good. I think one of the most, with the least amount of open label treatment. But do you think this will be feasible? And further, like other things like paracetamol and those sort of things, because you alluding to your previous comments.
I think in an ideal situation, I think I would focus on the patients with the high transductal shunt volume and have those patients randomized into expectant treatment and treatment. And then the question is, which treatment? Is it transcatheter closure? That would be very interesting, because then you don't have any effect of any drugs acting on angiogenesis. So that would be really nice. I'm not sure whether that's feasible, but I'm going to try and find out. I know that Afifa Kufash and Patrick McNamara, they are very eager and they say you should treat. And I'm going to be in a debate with them during a PDA symposium in Istanbul. I'm really looking forward to that, because I think we're coming to the same road. We're coming to get, because I think there are children that need treatment, but we have to we have to indicate them which patients are, but still the question is how to treat them. And that's the major question. However, still one thing to consider is that it's not easy to perform a clinical trial in these in this population. And I know my colleague and good friend Afifa Kufash had already mentioned it's impossible to do clinical trials in hemodynamics. Well, I don't know, because we showed that it is possible, but it's really, really, really difficult, and it takes a lot of time. And I've visited the centers many, many, many times, and I've been available 24/7. But it's possible, and in a collaboration, I think it should be feasible to perform a study like that. So that's hopefully one of the next steps.
Okay. Regarding that, I have one question, sir. If you think that transcatheter, closure of the duct is better, but when we compare it in low and middle income countries like India, where the population is so high, then it will be a difficult procedure, So the external validity of this will become very much difficult in countries like us, because we directly depend on. Currently, many of the centers use paracetamol because ibuprofen is not available with us. So we depend on paracetamol, and I don't know. Most of us feel like the duct is getting closed, but definitely the complications are there. So definitely there is an answer. But this question of how we will go forward becomes a difficult scenario.
Yeah, I think I still have to be within the same answers, that I would wait, and hopefully there will be a spontaneous closure. I wouldn't treat early, so no treatment within the first week. That's what we showed within the BeNeDuctus trial. After the first week, you can try to find and to work only, try to treat only those patients with a large shunt volume. And then you can either pick ibuprofen or paracetamol, and you can argue that hopefully the beneficial effects will outweigh the adverse effects in those specific patients. I think that's the best you can do with current knowledge. Yeah,
thank you. Thank you. Dr. Nilesh, next question you want to ask?
I think there was one about the pulmonary bleed. I think it was a comment, any genetic basis and all that. So I think in our population, probably.
Covered most of the questions, I think.
I think so. Yeah, I think we have covered most of the questions. So anyway, Dr. Manoj, over to you.
Thank you, Dr. Nilesh and Dr. Anita. It was an excellent moderation. Thank you so much for sparing the time for that. I would also like to thank Professor Willem de Bode. Yes, sir, you had presented one of the best sessions. We are starting 2023 with one of the best sessions with a lot of insights and food for thought. And on a topic that is probably the most controversial topic as well as neonatology is concerned. This topic has been there and it will continue to be there until probably neonatology exists. That is what some of us feel. So anyway, thank you so much, sir. It is an honor to have you here, and we look forward to having you more in our webinars as well as in physical meetings in the future. And looking forward to associating with you in the future. Thank you so much, sir.
Thank you very much. I really enjoyed it. I'm sorry for the dog, but I really enjoyed it. And thank you so much for your attendance. I really enjoyed the question and answer questions. We're all struggling with the same, and that's nice to know. And it would be nice to have some way of solution, I hope, for everyone, everywhere. So looking forward to meeting you, and hopefully we can collaborate and finding the answer so that at the end it will be possible, treat or not treat the duct. Thank you so much.
Thank you, sir. Thank you so much. And finally, I would also like to thank all our respected attendees who have been with us. Now the number has crossed 9,200 today. Registrations, people who are attending in various platforms, and then probably, I mean, some of you in your own time zones. So thank you so much for joining us. Looking forward to having you in our future sessions as well. With that, I take the liberty of closing today's session. Thank you so much once again.
Thank you so much. Thanks.
Thank you. Thank you.